All right, very good morning, everybody, and welcome to today's resident lecture. It's my pleasure to introduce Lena Weiss, who is a second-year resident at our institution. And this morning, she will talk about a rare disease. She will talk about liposarcoma. So enjoy the talk.
Thank you so much, Professor Lehmann, for this very kind introduction. I'm very happy to be talking about retroperitoneal liposarcoma this morning. Let me know if you can't hear me, then I'll try to speak up a little bit. So I'll start with a small introduction on soft tissue sarcoma in general, and then I will continue on to talk about a case of retroperitoneal liposarcoma, and we'll finish off with some take-home messages just as usual. So some essentials on soft tissue sarcoma in general. It's a malignancy of the connective tissue, which is of mesenchymal origin, and it's actually very, very rare. So the incidence is under 6 in 100,000, and this makes up about 1% of overall adult malignant tumors. The average age upon occurrence is 60 years, and there are over 70 histologic subtypes. Herein, the liposarcoma, as well as the leiomyosarcoma and the undifferentiated pleomorphic sarcomas are the most frequently found subtypes. You have them as well in various locations. So for us today, the relevant part is the retroperitoneum, where you can find about 17% of soft tissue sarcoma. And within that group, about 90% are made up of well and dedifferentiated liposarcoma, leiomyosarcoma, and solitary fibrous tumors. So let's continue on and talk a little bit about the tumor of Mr. X. He was a 70-year-old male who presented in an external outpatient clinic, and he's been having epigastric pain and some pain in his upper right abdomen for about a week and loss of appetite. Furthermore, he had lost weight of about 10 kilos over the duration of 6 months, which was intended, however, so we don't know the causality here. Upon examination, our colleague found a non-painful palpable mass in the epigastrium. So my question for you guys is, what would you do next? Does anyone have an idea?
Ultrasound?
Exactly, that's what our colleague did as well. And this showed a mass next to the right kidney. So subsequently, he went for a CT scan. And this showed an expensive retroperitoneal mass. And radiologists already gave us some suggestions in terms of differential diagnosis, which were sarcoma and kidney cell carcinoma. Here you can see the images of our Mr. X. And as you can see, it's quite a large tumor, which is very inhomogeneous in its structure, and it's pressing on the adjacent structures like the kidney, as well as the vena cava. And how is this typical for retroperitoneal liposarcoma? Clinically, it needs to be said that symptoms are usually very unspecific. So they're mostly associated with compression, some unspecific pain, some early satiety, loss of appetite, things like that. Some cases also edema of the lower extremities just because it's compressing on some of the main vessels. And when it comes to imaging, it needs to be said that the contrast-enhanced CT is the go-to method if we talk about imaging of the retroperitoneum. And here, what we do is we search for abnormal macroscopic fat. If you find any fat in a particular image that doesn't actually originate from the internal viscera, then you should always think of a possibility of having a liposarcoma. What is important here is that you identify the well-differentiated parts, just because this is essential for the following surgical planning. And furthermore, in order to complete a full staging, you should always follow this with a chest CT. These are a couple of examples. As you can see, it's very similarly, you have a very inhomogeneous tumor mass. And the image number B, you can see the dark part, which is marked with an arrow. This is actually also still part of the tumor. So some people might actually mistake that for just normal fat. And this is illustrated even further in the lower image, where you can see the two rather dense tumor pods, and some people might think, okay, that's just two separate tumors, but they're actually surrounded by the darker mass, which still belongs to the liposarcoma and is the well-differentiated part, which needs to be taken into consideration when you go for resection. So what's next here for our Mr. X? Does anyone have an idea what we would do?
Biopsy?
Yes, exactly. Very good. We would go for a percutaneous core needle biopsy, in fact. And I want to talk about this for a minute. It's actually the gold standard in terms of treatment planning. And depending on what you find in the subsequent histological analyses, the treatment planning can vary dramatically. There is often a fear of needle tract seeding, which has actually been proven in recent studies to be quite minimal, so a maximum of 2%. And the risk of local recurrence is actually also not influenced by having performed a biopsy before treatment. What you do is you take multiple needle cores, and usually in liposarcomas, retroperitoneal route is preferred when taking the biopsy, and you should always try and target solid areas of the tumor in order to avoid underdiagnosis. In terms of pathology, the specimen should always be evaluated by two separate pathologists who have experience in diagnosing different kinds of soft tissue sarcoma, because it's quite rare, as I already said, and it's actually very difficult. And it's one of the main factors that determines the prognosis of your patient, because it's essential for the overall staging based on the histologic subtype and the grade. As usual, the grading is based on differentiation, the count of mitosis and necrosis. And as you can see in this particular graph, the grade is highly correlated to the metastasis-free survival. And although this graph is on sarcomas in general, this is equally valid for liposarcoma. For the liposarcoma, there's 5 subtypes currently described by the WHO, and they each have their distinctive morphologies and also genetic findings. Relevant for us today because they're most frequently found in the retroperitoneum are the well-differentiated and the de-differentiated liposarcoma. Generally, when analyzing the samples, you would go for a general morphological observation, followed by an immunohistochemical staining and molecular genetic analyses like fluorescence and cytohybridization, PCR methods, and some amplification methods. And this is because, especially for the well-differentiated and de-differentiated liposarcoma, there are typical genetic aberrations. These are usually amplifications of some locations which are associated with or have been recognized as proto-oncogenes, and mostly found in almost 100% of cases is the MDM2 amplification, followed by the CDK4 amplification in about 90%. And I'll talk about this a little bit later in terms of relevance for therapy. So for Mr. X, does anyone have a suggestion of what we would do next? We would go for a multidisciplinary sarcoma board. And here we would talk about the different treatment options. That would be surgery, drugs, or radiation. And I want to continue on and talk about these options. So first of all, the surgical resection needs to be an extended multi-organ unblock resection that includes all adherent structures, even if they're not macroscopically infiltrated by the tumor. And our goal is the macroscopically complete resection. And in liposarcoma, wider margins are needed just because, as I mentioned with the imaging, it's often quite hard to differentiate the well-differentiated parts from the adherent fatty tissue. The surgical resection is also the go-to method when it comes to recurrence. Here you can see the 2 compartments that you generally use for orientation when it comes to resection planning. And as you can see, they're quite big. So this is big surgery we're talking about, which also needs preoperative measures that should be taken. And the anesthesiological evaluation would be the first step. And then this would be followed by a colonoscopy and a stoma placement, because most of the times you have to resect part of the colon as well. And furthermore, the stoma placement is also relevant due to that, and a nuclear renal function scan to make sure that the kidney on the opposite side to where you're operating is functional. And obviously this all needs to be included in a detailed informed consent when you're preparing the patient for surgery. This is just to illustrate again the different compartments that we're kind of aiming. And you can see often, or most cases, the kidney needs to be resected, and you would go quite thoroughly through the margin of the psoas muscle as well. And as I already said, the colon in many cases has to be resected because it's usually quite close to the tumor mass. And so the competency of the surgeon needs to be accordingly. How about radiotherapy? So generally, your first choice would be to do preoperative radiotherapy, and you would usually do that with 50 Gray in fractions. And it has been recently shown that in the case of liposarcoma, this actually has an impact and improvement on overall survival. So Bonvalot et al. Last year, they published a study which has been done in a multi-center and open label randomized setting. And interestingly, this was only seen specifically for liposarcoma, but not other kinds of sarcoma. Postoperatively, radiotherapy can be considered, usually in quite large tumors that are deeply located or very high dedifferentiated grade, as well as after an R1 resection. And this is associated with just a better local control, but not actually with an improvement of overall survival. Another word on chemotherapy here. So usually the response of liposarcoma differs according to the subtype and is actually quite poor for the well-differentiated and the dedifferentiated liposarcoma. And therefore, generally, chemotherapy is not recommended in a setting where you can resect the tumor. So let's come back to Mr. X. He received a resection in an external hospital, and then his pathology showed a dedifferentiated liposarcoma of quite a significant size of about 23 centimeters, so it was huge. And unfortunately, the dedifferentiated parts were infiltrating the margins. So we're looking at an R1 or even an R2 resection here. Subsequently, his case was discussed in a sarcoma board, and they recommended follow-up. And this was done. And 9 months later, he received a CT scan, which showed this image. So as you can see, unfortunately, we have a new retroperitoneal mass, which is highly suggestive of a recurrence. Therefore, I want to talk a bit about recurrence, and it actually occurs in about 20 to 40% of cases, so quite frequently, and mostly within the 2 years after initial resection. The highest risk factors are non-RO resection, as well as age, the general size of the tumor, and the histologic subtype and grade. Once again, illustrating the importance of having a good histologic analysis and pathology. The treatment is similar as for primary. We have another evaluation with a biopsy, followed by staging and a discussion in a sarcoma board. This was done as well for our Mr. X. He received a CT thorax to complete the staging just to make sure that there are no metastases. Also, they suggested to do preoperative radiotherapy and followed by restaging, including a colonoscopy, and then an en bloc resection, including all adjacent structures. And this we did here. As you can see quite nicely, there's the tumor mass, which has the pseudocapsule, and closely to that, you see parts of the colon. And in the situs, as you can see comparably well, the psoas muscle has been resected as well, and was kind of included in the overall resection, just to make sure to kind of get it all out this time. We were able to preserve the femoral nerve, and the blue line is basically the mark of the vena cava, just as an orientation in terms of compartment that you saw earlier. So what's the prognosis of patients with this kind of disease? Generally, and this is for liposarcoma overall, the survival varies according to grade. So for the well-differentiated liposarcoma, you have about 90% 5-year survival, but it actually goes down quite severely for the high-grade dedifferentiated liposarcomas to about 40%. And if you have metastatic disease, it goes down further to 15%. The major prognostic factors are, as I already said, above the grade and the subtype. And then secondly, the margin of resection. And this is illustrated in this graph quite interestingly. So you can see that the survival is severely impacted when you have a resection with gross infiltrated margins. And then other factors like the age and the tumor burden, which is the size and the depth of the tumor, influence the prognosis and overall the site as well. So we're talking here about retroperitoneal liposarcoma, and this is already associated with a lower rate of 12-year survival of only 32 to 50%. And seeing that metastatic disease is only associated with a 50% survival rate over 5 years, I want to talk about this as well. And generally, metastases are usually found in the lung or the liver, around 72% in the lung. The 5-year incidence is, once again, dependent on the tumor grade and subtype, and ranges between 10 and 40%. The majority, as well as in the case of recurrence, actually come up within 2 years after the resection. And a surgical metastastectomy can be performed if there's an isolated finding in the lung, for example, or the liver. But if that's not the case and we can't do resection, chemotherapy is the first choice. And this usually is anthracycline-based, so it's doxorubicin combined with ifosfamide. And there are promising novel targeted therapies for the well-differentiated and the dedifferentiated liposarcoma that, as I mentioned earlier, are usually associated with a poor response to chemotherapy. And these are targeting the molecules or the amplification loci that I mentioned earlier, the MDM2 and the CDK4. And there are different kinds of phase 1 and phase 2 trials currently going on to investigate these further, but they're actually showing quite promising results at the moment. So what comes next for Mr. X? Obviously, his case was discussed once again in the multidisciplinary sarcoma board, and he will be receiving surveillance. And usually, as I mentioned, the majority of recurrence occur within 2 years, and this is also valid for re-recurrence. So within this time, he will receive imaging every 3 months. And this would include a CT or an MRI paired with a serial chest CT. And after 3 years, you could usually extend the surveillance time to every 6 months. And then after 6 years, you could do annual checkups. So some take-home messages for you today. First of all, I would like you just to keep it in mind, to think of it. It's a rare disease, but it occurs. And if it does, no treatment without clear diagnosis. So don't be afraid to take a biopsy, because the fear of track needle seeding is actually not legitimate. Furthermore, don't work alone. Always discuss cases like this in a multidisciplinary board in order to kind of get the highest amount of knowledge on this particular disease. When it comes to resection, always do an unblocked resection and try to have clear margins. So yes, I thank you, and I'm looking forward to a discussion. And just in case anyone is interested, these are the detailed sources to the to the slides. And if you have any questions, any recommendations, I'm very happy to provide you with any recommendations here.
Thank you, Lena. I think you successfully made your talk against this background. I have at least some questions. You mentioned the role of the biopsy for retroperitoneal tumors. Do you know, or is that something that you should always do, or do you have conditions, or do you know about conditions that you should exclude, or it should be where you wouldn't do a biopsy?
So for retroperitoneal lesions in general,
Just a retroperitoneal mass, can you put a needle in at any time, or are there conditions that you should exclude before you do that?
so the majority of cases, I would say put a needle in it. There is, for example, one specific tumor, the pheochromocytoma, where you would have to be sure just from the imaging that it's actually that, and then you wouldn't have to do a biopsy. But generally, always put a needle in it.
Yeah, I think that those. I think Christian agrees. It's mostly pheochromocytoma and adrenocortical carcinoma where you would not do a biopsy, but otherwise you can put a needle into every tumor.
Thank you very much. Excellent talk. I have two questions. The first one is, you showed the study by Bonvalot that showed a real benefit of neoadjuvant chemoradiation. Should we do now chemoradiation in all patients, or should that still be in an individual decision on risk factors and so on? And in line with that, the second question is, does your histologic workup, the preoperative workup, does that have any decision-making factors? Would you do something differently in some subtypes?
Yeah, so I didn't understand all of it, but I think I answered most of it. So in terms of radiotherapy, generally the decision-making in terms of therapy is always an individual decision and should always be discussed within a tumor board. And for liposarcoma, this is actually also a little bit dependent on the specific subgroups. So the well-differentiated and the de-differentiated of low-risk type are the ones responding to the preoperative radiotherapy. So once again, you should discuss that in your board, because if there is a possibility that according to the imaging, there is a higher rate of high-risk de-differentiated liposarcoma, one might need to discuss if radiotherapy is actually a good indicator or not. But yeah.
Can I add something? Well, the difficulty with this trust study is that it contained only 260 patients, and they mixed up pathologies. So they also included leiomyosarcomas and liposarcomas. And in the end, the study was negative for the leiomyosarcomas, which are actually more aggressive and tend to metastasize into the lung. And it was surprisingly positive for the well-differentiated liposarcomas. So this study leaves us with a big question mark. Now, of course, it's always an individual discussion, but we should have some standards. And the standard is that radiotherapy is no longer recommended for all retroperitoneal tumors, but it may add a benefit, at least for well-differentiated tumors. So we tend to recommend it if they're clearly retroperitoneal. If they are intraperitoneal, we see those tumors sometimes. We don't do it because the margins may get less clear, and they're sometimes very difficult to resect after radiation. So it's another story there.
Thank you also from my side. Very scholarly presentation. I have one question. It feels to me like we are being very aggressive in terms of preoperative therapy. We're very aggressive in terms of operative strategies, yet recurrence still is a major concern. So what other strategies do we maybe have to think about in trying to bring down local recurrence rates? Is there maybe a role for intensified postoperative radiotherapy? Because retroperitoneal structures generally lend themselves well to radiotherapy. And maybe that is a site where we can do better?
Yeah, that's a good question. That was a strategy which was performed in some institutions for some years. And we discussed that sometimes at the tumor board, these intra operative radiotherapy. It didn't made it into clinical practice actually, and particularly with the advent of stereotactic radiation, radiotherapists tend to say we do not have a benefit, and it's quite an effort to do that inside an OR schedule, which is highly booked. The other point is we're still not at the point where all those tumors are really, resected in a proper way. Lina made an example, and this patient was actually enucleated. So that's, I think, the first part of the solution is us with the doctors that we stick to our plans.
Thank you, Lina, for this really great presentation. I have just a general comment. Many patients come here, they have been operated in other centers, and then they come here for evaluation of a R1 or R2 situation. And I think one cannot emphasize enough that those types of tumors really need to be treated in specialized centers where all different specialists are available, and a correct treatment plan can be set up before really starting the treatment. This is just a general comment. I think this is really important because we see a lot of patients coming here with an attempt to resect or incomplete resection. Thank you very much.
Yeah, I think that was a good word to the end. Thanks, Lina, again for your great talk. Thank you.